Managing nighttime agitation and memory care forces care teams into a difficult corner. To keep residents safe, teams often rely on antipsychotic medications. This flowchart illustrates a vicious cycle. The chemical restraints required to manage the night leave residents trapped in daytime drowsiness. At the same time, facilities are penalized, facing intense regulatory and scorecard pressures for their reliance on these drugs. Floor teams are caught in an operational catch-22. They are required to stabilize residents overnight, yet they cannot afford to pile more pills onto an already overwhelming pharmacological regimen. The clinical ideal is straightforward. Residents should be alert and engaged when the sun is up, and resting peacefully when it goes down. Relying on pharmacological interventions to enforce that sleep schedule creates a systemic failure, punishing both the patient's quality of life and the facility's operational standing. We can see how this trap operates in practice through a recent observational case study of a 71-year-old female resident. To manage her nighttime agitation, she had relied on an antipsychotic continuously for an entire decade. Over that time, her primary caregiver documented a steep clinical decline, specifically noting severe lethargy and a loss of cooperative behaviors. The chemical intervention used to subdue her at night effectively erased her ability to function during the day. To support her overnight stability without adding to her pill count, her care team implemented a different tool, the Brain Vitality Herbal Pouch. As you can see, this is a flat, rectangular, stitched fabric pouch with sealed edges. It is worn externally. A soft, breathable belt holds the pouch securely against the skin at the resident's navel. Unlike the drug regimen she endured for the prior 10 years, this intervention requires zero ingestion. Nothing is swallowed. This external format allows the routine to integrate into existing care workflows without compounding a resident's existing pharmacological burden. This cross-section diagram illustrates the core operational mechanism of the pouch. It functions with absolute zero physical mass transfer. We can prove this empirically. When weighed before and after a full night's use, the physical weight of the pouch remains identical. There is zero transdermal transfer taking place across the skin barrier, and the application bypasses digestive system pathways. By utilizing this external routine, care teams can support overnight stability while bypassing the risks of chemical absorption and drug interactions. The 71-year-old resident utilized this overnight routine for a 6-month observational period. During that time, her caregiver reported a specific clinical outcome. She achieved consistent, uninterrupted sleep. That overnight stability gave the care team the operational window they needed to safely and completely discontinue her antipsychotic medication. Establishing a reliable, non-invasive nighttime baseline was the mandatory prerequisite for eliminating a decade-long chemical dependency. As the medication fog lifted, her daytime alertness improved. For the first time in 10 years, she engaged in a nurturing behavior, reaching out to adjust her husband's quilt at night. This intervention restored the resident's core identity and cooperative humanity, qualities that had been suppressed by 10 years of medication. Facility management teams are navigating this same pharmacological trap across the memory care sector every day. Reach out to discuss integrating the Overnight Stability Pilot program into your existing workflows to support both your residents and your floor teams. Replacing heavy antipsychotics with an external, zero-mass routine allows your facility to achieve scorecard success while restoring resident dignity.